Hello everyone. In this video we are going to talk about the acute coronary syndrome and its changes in the ECG. So this is basically related to the ECG changes of the unstable angina, non-ST elevation MI and ST elevation MI and its relation with the walls and the coronary arteries. Again, this is a very important topic because so many patients come in the emergency department and critical care unit with certain signs and symptoms, and they have got ECG findings, which we shouldn't miss, because if we miss the changes, we can miss the patient. So try to understand the concept of it. And at the end of the video, if you think the video is useful to you and it can be useful to other doctors, then please like the video and share the video. And I request you to subscribe the channel and hit the bell icon. And this is the only way to help me grow the channel further. So here we will be looking at the kind of changes which are present in the ECG of a patient of the acute coronary syndrome. This acute coronary syndrome actually comprises of the unstable angina, non-ST elevation MI and ST elevation MI. Now these patients who are suffering from the acute coronary syndrome, they have got certain of the risk factor, like they are diabetic, hypertensive, they have a smoking history, got a family history, and they are mostly male. And there are many more other risk factors, but this is not the topic which should be discussed here. So when these patients present to the emergency department or the critical care unit, they come most of the time with the chest pain, shortness of the breath, irritability and vomiting, pain epigastrium. They may be having sweating, or in the elderly cases they are mute. So when you get an ECG of these patients as a doctor, in around like 25% of these patients, the ECG is normal. So a normal ECG in a patient with a risk factor and typical clinical feature, or atypical presentation in case of diabetic, elderly and female, ECG will be normal. So you need to look at the clinical picture of the patient. In rest of these patients, either it can be a T-wave inversions, like here the T is upright but this is coming down, so it is called T-wave inversions, or it can be ST depression, where we see this J point, it has drawn the isoelectric line and the T wave downwards. This is what we call the ST depression. Or there can be ST elevation, where we see the J point along with the T wave has gone up. In case of the lead V1 and V2, this elevation is more than 1.5 to 2 millimeter, but in case of all other leads, this elevation is around 1 millimeter. So one small box on the ECG paper is equal to 1 millimeter in depth and height. So that helps to know it. So these can be the ECG changes when you encounter a patient of the acute coronary syndrome. Now whenever you are encountering such a situation where the patient comes with certain signs and symptoms, you get the ECG and either there is a T-wave inversions or there is ST depression, then it means one thing, that the coronary artery is partially occluded by the thrombus. It's not completely occluded. If it is this is the normal coronary artery where you don't see any thrombus, but this is an coronary artery of a patient who came with a chest pain and has got the risk factor and has T-wave inversions or ST depression. The thrombus will be partially occluding the coronary artery. After 4 to 6 hours, you get the cardiac enzyme in these patients after getting the ECG, and if the cardiac enzyme, they are negative, we'll call it unstable angina, but again still it's a part of the acute coronary syndrome. But if the cardiac enzyme is positive, then it is a non-ST elevation MI. But in case the patient has got ST elevation on the ECG, which you can here see that this J point, it has pulled the isoelectric line and the T wave upwards above the baseline, then in that case it simply means that the coronary artery is completely occluded by the presence of the thrombus. You do not need any cardiac enzyme, and you are, once it is diagnosed that this is ST elevation MI, you are to start the treatment as soon as possible. Either you can go for the percutaneous coronary intervention, obviously you will have before angiography, but If that is not available, then the inferior choice will be the breakage of the clot with the help of the clot buster or the thrombolysis, like the tissue plasminogen activator or streptokinase. Now, if you look carefully, there is a benefit of having ECG, because this way actually you can find out which wall of the heart is under ischemia or it has got a compromised blood supply, and from that you can also assess which coronary artery can it be. For example, if the change is here, this is the change in T-wave inversions. If the change is in 1 and AVL, this is known as lateral wall ischemia. Why we are calling here the ischemia? Because if you haven't got the cardiac enzyme, then either it can be unstable angina or it can be non-ST elevation MI in case of the T-wave inversions or ST depression. So this will be known as lateral wall ischemia, and predominantly it can be the lateral circumflex artery which has got the thrombus. But in case of the inferior leads 2, 3 and AVF, see there is a ST depression. So inferior wall ischemia can again be unstable angina or non-ST elevation MI, because there is ST depression. So coronary arteries is partially occluded, and in this case it can be right coronary artery, because that supplies in most of the cases the inferior wall. Then comes the anterior group of the chest leads. Here you see there is an ST elevation, and if it is in the V1 and V2 only, it will be known as anteroseptal MI, and it will be ST elevation MI. You don't need to categorize it into unstable angina and non-ST elevation MI, because it is ST elevation. And if it is only the V5 and V6, it will be known as anterolateral, and the anterior pure are the V3 and V4, but V1 to V6 are the anterior chest leads, and the incriminated artery is the left anterior descending in most of the cases.